his few talks during the last few hours, and he's going to discuss about advances in IgA nephropathy and IgA vasculitis, overview and emerging therapies. Welcome, Professor Lars Pape.
Thank you very much. This is in fact the first time in my life that I had 3 invited talks within 3 hours, so thank you for inviting me to this. So I now like to speak about IgA vasculitis and IgA nephritis. For us in routine care, these are 2 quite different diseases because they're different to treat, and they run very differently, but in a way they share a lot of common pathophysiology. So before we start, maybe just shortly thinking about microhematuria in children, because this is something, if I go to my outpatient department, one of the most frequent diagnoses we have there is microhematuria, despite patients coming with proteinuria or with recurrent urinary tract infections or maybe with enuresis. But I think we see like 10 patients a week with microhematuria for diagnosis. In some countries, microhematuria is diagnosed, sounds better. Microhematuria is diagnosed quite often, for example in Japan, where school screening is done. It's important to do family history because of all these a kind of benign familiar microhematuria, which is now no more named that way, but included in Alport syndrome. You really have to clarify erythrocyte monitoring, immunology, albuminuria, sonography, and we always say if you have persistence of microhematuria for more than 1 year, and then you should proceed to genetic Alport's diagnostic, or if you have a proteinuria over 50 milligrams per millimole per liter. And Alport is the most, so at least one mutation out of the Alport spectrum, is the most frequent reason for microhematuria. And normally in children you do not need any urological diagnosis. Obviously you have to rule out kidney stones. But in some of these patients, it's IgA nephropathy, which is the cause. Often, then microhematuria is associated with, in fact, associated macrohematuria. But also, if you go for children just with microhematuria, at least IgA nephropathy is your second common diagnosis. But we will start with the easier one. We'll start with IgA vasculitis nephritis. I think now it's formally called IgA vasculitis nephritis. I think it's a little bit difficult, but it's somehow systematically. Before it was very German called Purpura Schönlein-Henoch in German, or Schönlein-Henoch Purpura, from these 2 people who described that first time, but now it's IgAN. And it's the most common vasculitis in children. And in more than about 30% of those patients with IgAV also have IgAVN. So nobody knows why it's 30%. And mostly those patients receive remission within 4 weeks, and only 2 to 3% are in the literature going to end-stage renal disease. I have to admit that in 27 years now, pediatric nephrology in 2 large centers, I have never seen a patient with IgA vasculitis nephritis that required dialysis or a kidney transplant. What is important is that there's a lot of complement and coagulation activation. If you have the nephritis, you have a rapid onset of the disease. It's very easy to diagnose because you see it on the skin. The standard therapy is prednisone for abdominal pain, but normally if it's not a rapid progressive glomerulonephritis, you don't need to treat and can just wait. So fortunately you invited me the right year here, which made my talk very easy, because just this year there are 2 publications giving the guidelines of the IPNA on children with IgA nephropathy and IgA vasculitis. So I will primarily just talk to you about these guidelines, but as you have seen in the title of the talk, we have new therapeutic options that are obviously not covered in that guidelines. So I will use the last third of my talk to show you what is just happening now with newer therapies beside that guidelines. And if you start with IgA vasculitis nephritis, the guideline primarily says obviously there's no single test. You have to look for clinical and laboratory criteria. And they say if you have Purpura-Schellern-Henoch, then you should at least look for renal disease. Sometimes this is not done. And the next question is, when do you have to perform a kidney biopsy? And they say you should perform it if you have an UPCR ratio above, I always remind, like 1 gram per gram or 1 to 2 milligram per grams or 100 to 200 milligram per millimole for 2 to 4 weeks. So if you have a modest proteinuria for 2 to 4 weeks, do a biopsy. And you should perform a biopsy if you have a mild proteinuria for more than 4 weeks. These are the relative indications, and if you look in table 5, the absolute indications are severe proteinuria or persistent long proteinuria and an impaired GFR. Because the only reason you do the biopsy is that you do not want to miss patients with a rapid progressive glomerulonephritis, because they need immediate treatment. And that's why they say biopsy only in severe proteinuria, long or medium proteinuria, or impaired kidney function. Obviously, these patients should then go in a follow-up for at least 5 years and should be monitored afterwards closely for the first 6 months, and then you can go to larger intervals within these 5 years. So is there any way to prevent EJAVN? No. There are studies that show that there's no reason, just if you have IgA vasculitis, that you just give glucocorticoids to prevent nephritis. And you should also not use heparin, dipyridamole, aspirin, montelukast, whatever, to prevent that. Okay? So no medication to prevent IgA vasculitis, nephritis. Then obviously you should monitor closely. You should reduce proteinuria below 0.2 milligram per milligram. And if you should not just treat with glucosteroids if you have isolated microhematuria or a very low-grade proteinuria. So the standard IgA nephritis vasculitis is not treated, but just closely monitored. If you have nephrotic range proteinuria and you do a kidney biopsy and see severe involvement, then you can start this 3 to 6 months course with glucocorticoids, or you can also use steroid pulses. You also would do that obviously when you have impaired kidney function or even signs of rapid progressive glomerulonephritis. Then you really have to start steroid pulses. And if this is not completely successful and you don't go into complete submission, then you might add CNIs, cyclophosphamide, whatever, as medication. What is contrasting is a little difference to adults, because they only ask for using IV steroids in case of RPGN, but despite that do not give any immunosuppression. Yeah? So I think it's quite straightforward and quite easy what to do. And if the proteinuria persists, they suggest performing a repeat kidney biopsy to know about the situation and to decide about other immunosuppressants. Obviously, you should give antihypertensives and reach very good blood pressure around the 50th percentile. And obviously, it's best to give ACE inhibitors, and you can also use non-RAS blockers, and you should do lifelong blood monitoring. But I think that's no real news. That is what we do in all patients with kidney diseases, at least with kidney malfunction or with proteinuria. If there's a relapse with proteinuria, you should do a kidney biopsy because you might not know what the reason is. And for relapses, more or less the same is true, only treat relapses if they are associated with severe proteinuria or with impaired kidney function. And in this manuscript, there is this wonderful diagram, and it's maybe a little bit difficult to see here, but this is the thing you could at least screenshot you and save you some, because it's a very easy guideline what to do. You do your urine analysis. If there's no proteinuria, you just monitor 12 months later. If there is proteinuria, it depends on the grade of proteinuria. These are the 3 yellow ones. And it depends on if you just treat, if you wait, if you do a biopsy, and how you treat. And if GFR is not normal, this is a green way to go. And if you have only sclerotic lesions, obviously there's nothing to do, but this is happening very seldom. And if you have IgA 4 or 5 in your biopsy and or an RPGN, then you really need serial pulses, MMF, and whatever. And there are some considerations. I think this is very nice, and it would have been much more difficult for me to show you something similar last year. This is what you should remember, how to work with IgA vasculitis nephritis. So then we switch for the other 2/3 of the talk to the more difficult disease. This is IgA nephropathy in children. It still has a low incidence, but on the other hand, it's the most common glomerulonephritis in children. And again, it's diagnosed via macrohematuria. That's what I told you before. And you might find this infection-associated macrohematuria. You do a renal biopsy if you have an urine albumin creatinine over 50 milligrams per milliliter. This is at least what the guideline recommends, but we know that there are countries that do kidney biopsies in all children with macrohematuria. I think this is not needed also because of all these Alport-like and Alport patients, what you can rule out by genetics, at least if you can do. Genetics, small number of patients has a fulminant onset with rapid progressive glomerulonephritis, and at least I have the experience with around 10 patients with IgA nephropathy that needed a kidney transplant, and opposite to IgA-VN. Okay, sometimes you have to tell the patients that if they have severe macrohematuria, they might develop erythrocyte casts in the kidney, and you need really to give them a lot of fluid or IV fluid to avoid acute renal failure. It's more common in boys and girls. I mean, age of diagnosis is quite old with 13 years. It's very difficult to say what the frequency of diagnosis is. I think this is a quite interesting study from 1918, and you see it really depends on how much screening for hematuria is done. And if you screen more, you see IgA much more frequent than if you screen less, as I told you, for example, in Japan. And if you look for the clinical characteristics, really some have just nephrotic proteinuria hematuria, some nephritic proteinuria hematuria, some isolated hematuria. Obviously no one has isolated proteinuria, but there's quite a high variability also with GFR. However, in most patients we see in pediatrics where we only diagnose IgA and GFR is normal. Proteinuria, and I think this is common knowledge, but I think this study here, 10 years old, is quite clear. As more proteinuria you have, as worse is the outcome of your IgA nephropathy, and as more you will have to think about treatment. And I think this is something I like very much about IgA nephropathy, because we often think it's not that severe. We don't see really a decline in kidney function. What you see here is in the pediatric cohort, you sometimes even if you have IgA nephropathy, your kidney function is becoming better. And starting with like around 15 years, kidney function is going down. If you're an adult patient, it's constantly going down. So if you have a patient, see her for 3-4 years, younger child, and you have some proteinuria and have IgA nephropathy, but kidney function as well, don't think you are secure. It takes some time before kidney function becomes worse. So here we come also to the guideline. They say what we always recommend, a careful patient history, obviously. We need a kidney biopsy to diagnose IgAN. I've just told you when to do it. Gross hematuria or small hematuria for a period of time, quite comparable to the vasculitis. They even say if there's some kind of proteinuria, you shouldn't wait too long, just some weeks to do the biopsy, not to miss IgA nephropathy. Obviously, you should also do a biopsy if kidney function is not good, and you should look for a lot of differential diagnosis. And again, also as in vasculitis, you should have a long-term, I think probably a lifelong follow-up of those patients with IgA nephropathy. You shouldn't lose those patients in transition. And families should have psychological and social support if you can do that. How about treatment? And that is quite interesting because it's quite different to adults. In adults, most studies like Stop IgA have not shown any benefit of giving corticosteroids despite RPGN patients. And in children, it's quite different. So obviously every patient should get a RAS inhibitor, mainly an ACE inhibitor if there's any proteinuria. You should also obviously reduce the blood pressure at around the 50th percentile. You should do some exercise. You should counsel the patients about the nature of the disease. You should not routinely use glucosteroids in all patients, but only in selected settings. And these selected settings are the stages of the disease in the kidney biopsy, proteinuria, and GFR development. And you should use additional immunosuppressive drugs sometimes if your steroid treatment is not completely working. This is here B. It's a little bit difficult which one to use. I'll show you later on. You should also look for vitamin D if you give steroids. Obviously, you should immunize the patients, and there's no real evidence for the use of fish oil. There's no real evidence for the use of a tonsillectomy. And if you have a really steroid-sensitive nephrotic syndrome that in the biopsy shows to be an IgA nephropathy, then you should treat it as a steroid-sensitive nephrotic syndrome, because often you manage to get the patient in remission. If you have an RPGN, as in IgA vasculitis, you should give steroid pulses followed by steroids, and sometimes, depending on the clinical course, other immunosuppressants. More or less the same is true for a relapse. That is something you treat quite similar to the original diagnosis. Sometimes it's good to make a biopsy to be sure that it remains to be IgA nephritis, and you should continue your treatment if you do not manage the patient to get in complete remission. And here again is from this publication is a very nice summary of diagnosis and treatment of IgAN in children, and this is something which is easy to follow, and I think it's a very good guideline for the use. Personally, I won't, in the interest of time, to go through that again, but it summarizes what I've told you before. And then let's spend the last minute on newer treatments beyond this guideline. There were some studies with MMF, but MMF did not really work as an additional agent, so it's not recommended for IgA nephropathy. There is a study with budesonide. There are several studies for adults, and budesonide works very well in adults because it just directly targets pia plaques in the gut, where we think that the pathophysiology of IgA nephropathy happens. So we have started to treat several teenager patients, asking before their health insurance if they would pay for that with budesonide, and you don't need to use the NephCon, the very expensive budesonides that are sold for the diagnosis. You can just use budesonide capsules that are very cheap on the market, for example for Crohn's disease, and they work probably is proper. The company wouldn't say that. And you have some effect and you spare a lot of steroid side effects. So that might become a good medication instead of steroids for at least teenagers. There's very good data on sparsentan, an endothelin receptor antagonist in adults, and the sparsentan reduces proteinuria about 50% in adult patients. So studies in children are starting, and I think sparsentan will also become an additional medication in some years also for children with proteinuric IgA nephropathy. There's a study of iptacopan in IgA nephropathy. You see again New England Journal of Medicine. So quite impressive study, and you can see in the figure also a really significant change in 24-hour urinary protein to creatinine ratio. Iptacopan is a factor B complement inhibitor, inhibiting thereby 3,3 to degradation to 3,3A, and it's a little bit similar process as we have, or pathophysiology as we have seen in CABMR, and iptacopan is very expensive, but probably will also become an additional medication in pediatric IgA nephropathy within the next years. And this is an actual update on the treatment of IgA nephropathy, and also not so far away from what we have seen in CAMR. So you have treatment of autophagy. You can regulate your complement activation in IgA nephropathy with different compounds. You can regulate your immune response as in CAMR with B-cell and T-cell modulation, which is different. You can regulate your mucosal immunity by targeting GOLD, by budesonide, for example, IgA protease and antibiotics, and you can regulate your inflammation, for example, with sparsentan, as I told you before. And the actual hypothesis is a little bit more complicated of IgA nephropathy. It's a kind of three-hit idea. You have increased levels of galactose deficient IgA1A. You have a production of galactose deficient IgA antibodies, and those formulate circulating nephrogenic immune complexes, and these immune complexes then hit the endothelium and do absolutely the same as in CAMBR. They induce complement and all the other things. So it's a different pathophysiology in the beginning, but in the end, similar things are happening, and this is why we see a lot of similar drug names here. And the last two slides on prognosis. So many children have a GFR drop at some time points, and many in adult age. Some need kidney transplantation early. Good predictors are blood pressure and proteinuria over the course, but not at biopsy time. And however, as I told you, you should use immunosuppressants more than in adults, where steroids are used in a very few patients. And if anybody is interested in the prediction of the course of your patient with IgAN, there's a very good online prediction tool that has been published here, where you can type in the data of your patient to get a very good prediction how kidney function will develop in the next years. However, we all hope that the prediction will be much better, because some of the new compounds I've just shown you will come into action in children in the next years. And this is just a screenshot of this calculator, where you can type in the data of your patient, you see which questions are asked, and then you get a very good idea for pre and post biopsy IgAN patients, what their clinical course is, and if they might need severe interventions or if they don't need them. So thanks, and sorry for talking 2 minutes longer.